Good afternoon, everyone. As Sandra mentioned, I'm Leanne Myers, and I'm the Chief Clinical Officer here at Perfect Serve. First of all, I really want to thank you all for joining us today. I know how busy the schedules of healthcare professionals can be, and I promise today's webinar will be time well spent. Before we kick things off, I wanted to give you a little background on today's webinar. In late November, Perfect Serve conducted a webinar in its series regarding clinical communication challenges that Orange Coast Memorial Medical Center overcame. This webinar was very well received, but yet it was very clear based on the responses and the questions we had that there was an appetite out there for more information around the topic of clinical communications. So as we did our research, we are very pleased to sponsor and have with us today an expert speaker in this area. Let me take a moment and introduce you to Dr. Alan Ronstein. Dr. Ronstein is currently a practicing internist in San Francisco, California, a medical director for Physician Wellness Services in Minneapolis, Minnesota, and a consultant in healthcare management. Dr. Rosenstein has over 140 nationally recognized publications and has had extensive national and international lecture and consultation experience in the areas of care management, clinical decision support, nurse-physician-staff relationships, and behaviors affecting patient safety, quality, satisfaction, and clinical outcomes of care. Thank you very much today for joining us, Dr. Rosenstein, and now I will turn it over to you.
Thank you, Leanne, and welcome, everybody. Today's topic is a multidirectional approach to improving communication in the health delivery team. I think one of the points that you're going to learn, if you haven't learned it already, is that communication involves a multidisciplinary perspective with many contributing forces that are influencing people's acceptance and reaction to appropriate tasks. So if we look at the learning objectives, the first one is to discuss the impact of environmental pressures and healthcare reform on attitudes and behaviors that affect patient care. The second is to develop a business case for the benefits of improved communication and team collaboration and how it affects quality, safety, and efficiencies in both the process and the outcomes of care. Next will be to discuss specific strategies to improve communication and coordination. And then lastly, to discuss strategies to enhance patient, staff, and physician satisfaction. There's a lot of information as will be forthcoming in the slides, and I won't be able to go through everything in detail, but you all will have access to the full PDF outline once the conference is concluded. So why is communication so important? In today's healthcare environment, we're seeing increasing regulatory involvement and certainly increased complexity. There's a bigger focus on cost control. There are changing models of care. What used to be an independent cottage industry is now moving into group practice or employed practices or system-wide foundations. There's a multiplicity of caregivers. It's not just the physician who's involved with healthcare. Changing clinical roles and responsibilities, physicians, nurses, other staff. Certainly advances in care management. It's difficult for any physician to stay on top of what's going on with medical diagnosis and treatment. There's certainly increased use of technology and electronic messaging, which has certainly positive advantages in information flow, but at the same time changes relationships because it's now electronic rather than person to person. There's greater expectations, there's more accountability, and now what we're seeing based on some of the initiatives that are coming from Medicare and others, there's more and more respect on true population-based management rather than individual diagnosis and case management. And all this calls for the need for more efficient, coordinated, collaborative care, which is hopefully the point we're going to stress during today's session. Today's healthcare environment is extremely complex. It started years ago in the 1980s with utilization controls, changing the way we're reimbursed more on fixed dollar reimbursement rather than fee-for-service. Then it moved to managed care and managed competition. Now the throes are under healthcare reform, which I'll talk about in the next couple of slides. And basically what's happening is we're all being held more and more accountable to demonstrate that we're providing appropriate, effective, high-valued care, and there's a bunch of performance metrics that are being used to show us what we are doing or not doing. So what is healthcare reform? This is a definition that comes from Webster's dictionary. And if you look at the little box, I'm going to read definition B and C. Definition B is to amend or improve by change or form or removal of faults or abuses. And definition C is to put an end to an evil by enforcing or introducing a better method or course of action. And being a healthcare provider, I know a lot of us are looking at healthcare reform as something that's not in our best interest, and they look at it as being a negative evil force. So what's really in the Affordable Care Act? This was signed in March 2010, and the basic components were to try to provide access and affordability to care. So it covered all the essential benefits. There were no pre-existing conditions. One of the things that it did is it established state-based health insurance exchanges, which meant that the public at large could now go and look at the state or federal sponsored plans and get affordable health care without any pre-existing clause. The second part of it is an expanded Medicaid, so more and more patients will have access. More and more, the poverty level was raised up, so more and more patients will be thrown into the insurance coverage. So from providers, we're going to see more and more, hopefully see more and more patients coming to us because now they can afford care and it's covered through insurance. There's employer mandates and individual mandates with fines or credits based on whether or not you sign up or not. The other big issue is healthcare reform and value-based care. It's a big issue for us who are practicing medicine, and I'll talk about that in the next couple of slides. And then lastly, the accountable health care plans. The accountable health care plans basically are groups of physicians and hospitals and other members of the provider community who now jointly go out and try to get selective contracts from Medicare and others. Now, the whole important piece of all of these accountable health care plans is to build very strong partnerships between the systems and the physicians and the staff, which truly is going to depend upon efficiency and collaboration in order to make it a profitable endeavor. Value-based care. Well, prior to value-based care, there's a lot of fixed dollar reimbursements, per case reimbursement, per diem reimbursement, prepayment reimbursement. So providers are under the gun to try to provide appropriate, effective, high-quality care because not only that's what you want to do, but it certainly has a financial impact. On the right of the slide is a metric performance report card that I had put together, which looks at all the individual utilization, coding, readmission, core measure objectives that the hospital stands to benefit by if they do well and get penalized if they do poorly. So if we look at what are the pay-for-performance incentives, and this is what's coming from Medicare, this year there's a 1% withhold of all your Medicare payments, and if you have a typical hospital of 150 beds, it's probably going to have Medicare payments that are well into the $500,000 range. So when you talk about 1% of a withhold, that's a lot of money. So for that 1%, 70% of that 1% is based on your compliance with core measures, and 30% of that 1% is based on patient satisfaction, which is a key issue with communication. Is a 1% penalty withhold for hospital readmissions. If you have an acceptable readmission rate, you get this money back. If not, you lose that money. There's care denials through the RAC. The RAC is the Recovery Audit Contract. Is very scary for hospitals nowadays, where retrospectively people are looking at previous hospitalizations and saying that if they didn't meet criteria, you're going to have to pay back the money. So this is a crucial issue for the hospitals because payments can be in the $100,000 range of money you already received. We already know about the no pay for adverse events. In 2014, there's going to be 1% withhold on mortality, and then they're talking about another withhold in 2015 for cost incentives. So what a lot of this does is it puts more and more pressure on healthcare systems and on all the providers and clinicians associated with that system to do what they can to provide appropriate, effective care. If you HCAHPS is one of the key initiatives, and if you go on to the Medicare site, which is Medicare.gov, the first two questions I circled are patients who reported that their nurses always communicated well. The second one is patients who reported that their doctors always communicated well. So obviously this is a financial incentive for all hospitals to try to improve communication. It's also important because that's how you're going to get better outcomes of care. So what's the impact on providers? And the reason I'm going into this amount of detail is we're going to talk about improving communication, but part of improving communication is to understanding the world that everybody lives in and how they're being pushed and pulled in different directions. So hospitals are worried about economic survival. They're seeing changing models of care, whether you purchase physician practices, whether you change services, whether you develop a foundation model. They're going to have to look at their contracting. Who do you want to contract with? What are the rates? What are the provisions? There's more and more mergers and acquisitions going on. Very few independent hospitals being left, certainly in the metropolitan areas. And there's certainly a focus on improved care management. And as I'll go through later, communication, collaboration are key to effective care management. It's not the protocol. It's what people are doing in reaction to the information and accountability for task completion. So care management is going to involve staffing. It's going to be team-based care. It's going to be integration of all the people who are delivering care, true partnerships. It's going to be full-spectrum care, not just the emergency room, not just the inpatient admission, not just the rehabilitation. It's the entire spectrum. And the focus is going to be on appropriateness, effectiveness, and efficiency, and also to get the best quality and safety and improve satisfaction. So for the staff and the physicians, they're getting stressed, they're frustrated, they're actually becoming disillusioned because, everybody is telling them what to do, and all they want to do is to practice best medicine. So what are they going to do? Well, I'll just go through the status quo. Can I better adjust to the environment so I can play an active, exciting role? Do I have to change my practice or change my delivery model? Nurses are finding that their schedules are changing, their demands are changing, and maybe moving into other positions. A lot of physicians are getting frustrated with independent practice, and either they're joining groups or become salaried or leaving the profession. Changing jobs, changing careers, retirement at an earlier age, and this certainly has an issue around workforce implications and clinical care implications. Remember, previously with reform, we're talking about more and more patients are going to now have affordable insurance, which is going to put more demands on the systems that are taking care of those. And if people are frustrated and leaving, maybe we don't have the right capacity. So a lot of it has to do with the way people behave. So I have a spectrum of a behavior, what you want, and this is true for everybody, but I'll really focus on the physicians and nurses in particular. They really need to be fully engaged and collaborative. If you have a nurse and a physician who's doing that, great. Use them as your clinical champion. The second level down is they're engaged and they're participative. They're not going to be a leader, but they're still doing what you'd like them to do. And then you get into the areas where behaviors are not what you would really want. Non-compliant behaviors. They're not following the protocols. They're not washing their hands. They're not doing charting. They're not making themselves available. They're not responding. They're not communicating. And then you can get passive-aggressive to truly disruptive to destructive. So if we look at the right, I already talked about the non-compliance as the mid-road. With physicians, when they're truly disruptive, they're angry, they're yelling, they're demeaning, and usually this is very overt, it's short-term. They really don't have any malintent. It's just they need to take control, and because of that, they're barking and giving orders, and they're not thinking about how it's being received. When you look at nurse types of disruptive behavior, it's more the passive-aggressive. There's actually a term for it called horizontal hostility. What it does, it's more of an undermining, so it's more of a sabotage, and it's often more difficult to deal with. But those three things, overt, noncompliance, and passive-aggressive, can definitely affect communication efficiency and outcomes. So I've done a lot of research when I was working at VHA and published a lot on disruptive behaviors. And we define disruptive behavior as any inappropriate behavior, confrontation, or conflict ranging from verbal abuse to physical or sexual harassment that can potentially have a negative impact on patient care. That's the key point. And luckily, if you look at the bar graph, there's very little in the way of physical abuse, but it's a lot more in the disrespectful, demeaning, abusive, condescending type of behavior that really impacts individuals. So we've done a study. We found out how often this occurs and where it's occurring. And what we find is or three-quarters of the organization, when you survey them, we've literally had 10,000 surveys from probably 400 hospitals across the country. Three-quarters of them have witnessed disruptive behavior in physicians, two-thirds in nurses. And not surprisingly, yes, where the particular specialties, It's certainly the high-intense individuals. It's general surgery, neurosurgery, cardiovascular surgery, orthopedics, anesthesia, OBGYN. It also extends into the ED, into hospitalists, into even some primary care doctors. So what we found is that 3 to 5% of the staff are truly disruptive, but also our research has shown that 50% of them are actually poor communicators. So we asked this question, and this is going to be very important. Again, we're going to talk about communication tactics, but we're also talking about what's going on with the individual that you're asking to communicate. So we asked this question, how often does disruptive behavior result in the following? And I'll just go to the graphic and you can see the results. What we did in the graphic is we highlighted anybody who answered the question, sometimes, frequent, and constant. So they're under stress, they're frustrated, they lost their ability to concentrate. 92% of them felt that there was reduced team collaboration, 89% reduced information transfer, 95% reduced communication. So there is a significant issue on the impact of the individual who's the subject of this disruptive event. And then we asked if there was a specific link between disruptive behavior and the following. And again, we only accumulated the sometimes, frequent, and constant. And we asked, adverse events can occur, medical errors can occur, compromises in patient safety, compromises in quality, mortality. 25% of them actually felt that the mortality results from these type of disruptive events, and certainly reduced patient satisfaction. Then we asked, are you aware of any specific adverse events that did occur? Now, adverse events are things that happen that probably shouldn't have. To the best of our capabilities, they still occur less than 1% of the time, but here 18% of the groups said that they would witnessed an adverse event. And the lucky thing on the next slide is that 80% of them felt this could have been prevented. And then we actually didn't ask for comments, but people would write comments in the margins, on the sides, and the back of the papers. And we had literally thousands of comments. If you want to read these, we publish this over and over again in the different specialty journals. And some of them are just really thought-provoking. So I'll just read you a couple on the first bullet point. Most nurses are afraid to call Dr. X when they need to and frequently won't call. Their patient's medical safety is in jeopardy because of this. We skip down to the fourth bullet point. Poor communication post-op because of disruptive reputation resulted in delayed treatment, aspiration, and eventual demise. Then I'll read you the one right before the bottom, the next to last. Many incidents are preventable if both parties are willing to listen to each other, but many doctors are unwilling to accept the nurse's opinion, just as some nurses are unwilling to listen to the opinions of LVNs, techs, or CNAs. And it may have to do more with the entrenched pecking order that exists in most hospitals. So what's the call to action? Well, for a long time, until we started publishing this, and again, as a result of our publications, it's now a Joint Commission mandate. To get accredited, you need to have a disruptive behavior policy. And I've given you the references in the prior slide. But there's some reluctance on the organization. Well, they're not aware that this is going on, or they're willing to tolerate this. If you counsel somebody for being disruptive, or you could potentially antagonize them, and they say, you know what, I'm going to bring my patient somewhere else, and you're potentially going to lose revenue. There certainly is this issue about hierarchy and boundaries and sacred saints. Positions are typically autonomous. We don't like to get involved in their process. Is this hidden code of silence? Is this conflict of interest? Well, if I say something, I'm not going to get referrals from this physician. And lastly, do you have the right structure and skill set to deal with this type of issue? But if you don't act, compromise in staff relationships, compromises in satisfaction, compromises in retention and recruitment, defects in communication, which can lead to quality, safety, fines, liability issues. I already mentioned the Joint Commission standard. And then lastly is your overall reputation. So I'm not going to go through this slide, but these are the consequences. If you lose a nurse or you lose a physician, it's going to cost you not only dollars, but it costs you in the time that they've had invested in their experience until you get that next person up and running. There's certainly, I mentioned the no pay for adverse events. This is based on a lot of research that I've accumulated, and it talks about the cost of a medical error, the cost of an infection, deep vein thrombosis, pressure ulcers. Malpractice lawsuits, if you get involved in a lawsuit, you're talking about $500,000 in prep and liability. In California, you actually have fines for adverse events. Certainly the impact of patient satisfaction and reputation, particularly if they're looking at the sites like satisfaction scores, or they're going through the social media of what's going on in the hospitals, and the patients are using this as an indicator of where they want to go. The compliance issues, this is a non-compliance, they don't document, they don't code, they're not efficient in utilization, they don't wash their hands, which can have an impact on quality, is eventually a slowdown in productivity and efficiency. And in one article that I read, communication inefficiencies in a hospital can be as much as $4 million in lost costs. So what do you do? Again, it's not as simple as having communication. That's what I'm going to talk about in the next couple of minutes. You need to have a strong organizational culture that really recognizes what's going on, recognizes that everybody's part of a team, and you're really focused and aligned around patient-centric care. In order to do this, you need to have the right leadership, the right staff, and the right resources devoted. And what you might want to do is to do an internal assessment to find out what's actually going on, because part of improving communication is to find out what's bugging everybody as to why they're non-compliant, or they're angry, or they're resistant. Then I'll talk about the structured education and the special skill workshops in a minute. And then in the back end, you really need to have policies, procedures when things are not going according to plan, and be able to intervene and try to do this where you're actually looking at salvage rather than discipline, because you really want the staff to continue to do what they're doing, but it may require some behavioral modification. And everything is done to reinforce patient safety initiatives. So the goal overall is to improve communication efficiency. I think a year and a half ago I had written this article called Physician Communication and Care Management, the Good, the Bad, and the Ugly. So what are the communication priorities? Well, the first one is physicians need to communicate with other physicians. Now, I remember I mentioned the complexity. When I'm in the hospital and I'm looking at a patient, there's 4 or 5 physicians going on. You've got the surgeon, the infectious disease doctor, the oncologist, the internist, the nephrologist, and they all are on their individual paths, but somebody has to coordinate their care. One, to get better flow, efficiency, and appropriateness, but also you need to communicate to the staff. The staff is nursing. The staff may be case management, maybe discharge planning. You also need to better communicate with the family to set expectations, because if there's 5 different doctors giving 5 different recommendations to the nurse, to the case manager, to the discharge planner, and the family, think of the consequences. So we really need to recognize what our communication priorities are. I'll go through some of that communication training. And then if you look at process and outcome efficiency, what you want to do is you want to reduce unnecessary variation, and you want to promote best practice care. So you need to have the right guidelines. You need to have artificial intelligence. And also you need to have information flow, which means people who need to make decisions need to have timely access to that information and take accountability for following up, so the next person in the chain of what we need to do it gets the information and can respond appropriately. But as I'm emphasizing, structure and information flow are crucial, but also the human factor issues are just as important. And then when physicians or nurses or staff members are not doing well, alert them, coach them, and counsel them, and I'll talk about that in a moment. Well, that's all well and good in a perfect world, but there are definite communication barriers. One is, are people aware that they're not communicating? Do they understand why communication is important? Do they accept responsibility that they could do better? And a lot of this is based on their values. I'll talk about this, what motivates people's behavior, is issues around age, generation, culture, events you've gone through, and your personality. Is certainly an influence in training. Unfortunately, healthcare is in a hierarchical system where the physician is on top, and because of this, some people may be afraid to approach him, and they deal autonomously. Their approach is command and control, so this is a potential communication barrier. A lot of physicians, particularly when you get to specialists, they're not thinking about the patient, they're focusing on the organ, maybe the disease, less likely the patient. We're all stressed for time, we've got competing priorities, we're distracted. We need timely and appropriate and accurate information flow. There's segmented care. The hospitalist, the intensivist covers them in the in ICU. The hospitalist covers them in the inpatient setting, and then who's going to cover them on once they leave? And then this growing clinical and cultural diversity. 40%, at least I'm out here in California, 40% of the staff and probably 40% of the patients are either not American-born or American-trained, and English may actually be a second language. And there's a growing amount of fatigue, stress, and burnout, which is crucial, and I'm going to spend a little bit of time about this because it really is impacting the providers' attitudes and behaviors. And then lastly, are they willing to change? So recognize what communication objectives are. In the short term, you need to exchange information, you need to deliver a message, you need to respond to a message, you need to create shared meaning and understanding, you need to set the expectations, and make sure there's task accomplishment. In the long term, it's important for building relationships and collaboration, increasing understanding and clarifying expectations, enhance compliance, reduce the likelihood of communication gaps, and improve overall care efficiency and satisfaction. So we need to create solutions. One solution is raise levels of awareness. It's pretty much similar to what I've been talking about. It's the business case of why communication is important. The organization needs to be committed. You need to have the right processes, procedures, and education and skills training. And when individuals have problems, you really need to try to provide them with support. So what influences behavior? Again, I'm talking a lot about what makes people be the way they are, and a lot of it has to do with either internal or external. How old they are, what gender they are, culture and ethnicity, life's experiences, and overall personality. And then on the external side is training, the healthcare environment, the work environment, personal issues, and issues contributing to behavioral health, which can actually affect their attitudes and behaviors. So these are the internal factors. These are all discussions by themselves. With a multi-generational workforce, remember the baby boomers and the veterans are very loyal and committed. They'll work all day. They'll stay at a job for 40 years. When you start getting to the Generation X and Yers, it's a little bit different. I'm here till 5, then I'm going. I'll work here 2 years, and I'm not really sure I should spend the extra time here. Men are from Mars, women are from Venus. They're definitely, particularly under stress. Men behave in a certain way. They become more dominant and maybe aloof, whereas women typically tend to talk to others and get a group consensus. Diversity as to how they view gender, hierarchy, power, and assertiveness. And then certainly personality based on some of the Myers-Briggs and all the other personality work definitely contribute how people are behave and receptive to communication. Training, this is a big issue nowadays. Training, at least when I went through, and probably up until about 5 years ago, it's a hazing experience. You don't know anything. Stand in the corner. You lose your self-esteem, and you get technical competence, and you get knowledge competence. That's how you survive. But there's been no training on personal skills or communication skills. But luckily now what we're finding is that medical schools are now beginning to introduce team training, personal skills, and collaboration skills early on during the medical school curriculum, where they're actually combining the medical students with dental students, nursing students, pharmacy students, and any other specialties that they have at that particular organization. Now, stress and burnout is a crucial issue, and as you see some of these results, it's really impacting our physicians. So again, if you want them to be good communicators, you need to understand what's bugging them. And there's been a lot of research coming out showing how prevalent stress is. It's between 40 and 50%. It's not only stress, it's burnout, and it leads to other things. It leads to depression, it leads to true anxiety disorders, can lead to substance abuse and even suicide, and it actually starts in medical school. And in last year, I published this article in the American College of Physician Executives talking about physician stress and burnout, what can we do? And a lot of this was based on a survey that we had done through Physician Wellness Services and CHECA. And we asked about, okay, what are the external factors that are causing burnout? Well, it's the economy, it's healthcare reform, it's intrusion. And what are the work-related causes that are causing burnout? Too much paperwork, too many hours, schedules, I'm worried about malpractice, everybody's interfering, there's too much change and complexity, and the last thing is the thrill is gone. So what needs to be done? Well, I got to make more time for myself. I need to exercise. I need to relax. The real issue is, are they finding the time to do it? Because when you get that next patient call or that next demand, you jump right into it. And then we ask, what are the organizations doing? Well, we're going to put on stress management courses. We're going to have wellness initiatives. We're going to provide workshops. The only problem at the bottom of the second graph is less than 15% of the physicians who were surveyed, and this is over 2,000 physicians, felt that the organization actually offered these in a proactive manner. And it's not just physicians that are stressed. We also have nurses, we also have administrators, and we also have the patients and the family. Their stresses are due to different concerns. And one of the things that's continuing to creep up from nurses is the issue about compassion fatigue. So what are the consequences? Well, for the organization, you worry about culture and morale, you worry about turnover, you worry about care coordination, you worry about the increasing incidence of either inappropriate or disruptive behavior and what it can do to communication, collaboration, quality and safety, and satisfaction. On the physician and the staff side, they're unhappy. They're becoming more irritable and moody. They may get sleep disturbances and fatigue. They can have physical components and emotional components. And what this can lead to is performance liability and issues actually about, do I want to continue to do this? So in order to support, this is a big issue, and organizations need to pay attention. And what they need to do is to work with their employed staff or physician staff to get them to better adapt. So some of it is either onboarding or a cultural fit. When I was working at the hospital, I used to meet with the new physicians and talk to them. This is what the world is like. This is what case managers are going to do. This is what some of the committees are going to do, and make sure that they understand. Again, aligning incentives, raising their awareness. And then if there is a problem, we need to intervene early. What we need to do is to work with people who are dissatisfied or irritable, talk to them a little, what can we do to help, rather than waiting to the fact that they don't respond to a call or something bad happens to an individual patient. So how will you do this? Before we get into communication skills, it really is relationship skills training. One thing is emotional intelligence. One of the issues with physicians, because, and maybe not just physicians, but the way they're trained is, again, they're very dictatorial. Physicians give orders, and part of the process, you don't really understand how this is impacted on the person you're talking to, whether it's a patient or a nurse, because their value systems and their priorities and their concerns may be maybe a little bit different than yours. So emotional intelligence is actually opening up the physician or anybody's mind to be more mindful of what the other person really needs to hear and how you can better communicate with them. Based on the individual predicaments in your own organization, sensitivity training, diversity management, cultural competencies, sexual harassment, stress time, anger management, conflict resolution may all be appropriate courses. Then we look at specific communication skills training. And again, emotional intelligence and mindfulness are a key to open up people to communication skills training, because they really need to understand what communication is, but communication is a two-way street. You need to understand the other side's perspective. Well, one of the things you can do is you can do scripting. Either the SBAR tool or Quint Studor has a tool where the nurses will read over the script before they call the physician. The SBAR is it promotes expediency and appropriateness of technology flow. S is the situation, B is the background, A is the assessment, and R is the recommendations. It's a quick way to present this in a two-way conversation to get the information you need. Team training has been excellent. A lot of this is based on the crew resource management, the TeamStepps model, nuclear medicine, the Ferrari pit crew. There's a whole bunch of different programs. The whole idea is to understand what your role is as part of a team, to trust the members, know what your roles and responsibilities are, anticipate what's coming next, be able to speak up if you see something that you have a question about, and then talk about it afterwards. What went well? What could we do better? Conflict management is crucial, particularly for people who are more irritable now, given some of the current environment pressures that I talked about earlier. And then basic communication skills. And some of this is AIDET, SBAR, the STAR system. Acknowledge who you are, introduce yourself, spend time with them, explain, engage, show that you really care and you're empathetic. Spend the time. A lot of communication is based on not so much what you say, but it's your tone, it's your posture, whether or not you make eye contact, whether you're truly attentive or you're distracted. Demonstrate empathy, develop trust, make sure you explain, try to avoid conflict, set expectations, and offer follow-up contact to the individual if they need some further clarification or they have any questions. I don't have time to go through this case example. I'll let you read it on your own. What I've given you is 2 case examples of how communication can be short and abbreviated and the impact that's going to have. And the second bullet point is more of somebody taking the time to explain what's going on, who you are, what's going to come next, what your expected course of treatment is going to be, and what your follow-up is going to be. Do you have any questions? So in order to promote communication efficiency, you need to have the training and the right skill sets. As I said before, mindfulness and emotional intelligence is crucial. You need to be engaged. You need to make sure you're providing clarity, avoid distractions, and avoid conflicts. And then what you need to do is improve information flow and efficiency. Now, particularly we talked about before the growing amount of technology dependence rather than personal contact, which is positive and negative. The positive part of technology concept is that you're connected, you get instant messaging, you get coordination of care, and you can respond capably. So anything that gets information to the physician, to the case manager, to the nurse, to the physical therapist, whoever, timely information, this is going on, alerts and reminders, and it's sent out to the entire team. It's a perfect way to coordinate care, set expectations, hold accountability, and accomplish the tasks that you really need to accomplish. Now, when you do have truly inappropriate behaviors, you really can't, as I said, you can't afford to look the other way. So what you need to do is you need to have a policy. This is appropriate behaviors. These are the ramifications of inappropriate behaviors. If there is a problem, you need to have a consistent reporting process where a group reviews all the individual incidents and without conflicts of interest or bias makes a determination on what follow-up might be. If you're having an interaction with an individual, there's a couple of different ways you can do it. The easiest way is to have an informal coffee time conversation with them, but make sure you choose the right time and place. Make sure you don't provoke further conflict. Show them that you really understand what's going on. Ask for their input, listen, and then advise. The last bullet point is value is a precious resource. Again, I go into all of this about the fact that physicians, nurses, physical therapists, pharmacists, all they want to do is to do their job and do it the best they can, but sometimes they don't understand what's getting in the way, and you need to try to help them rather than sanction them. If you do have a disruptive individual, it really takes a dedicated, well-skilled intervention team. I'll put the action plan on the very bottom. Coffee time is the informal discussion. You know, most of the people, when you bring it to their attention, will say, thank you for bringing it to my attention, I'll do better. You raise their level of awareness, but if somebody who's more of a chronic abuser, you need to do more of an authority intervention. Recommend sensitivity training, communication skills training, team training, diversity management, conflict management, and in some very few cases, unfortunately, you'll have to sanction or discipline because the people are not responding and not receptive to any recommendations for improvement. What you really want to do is to make sure you reinforce all the concurrent organizational initiatives. Communication is so broad spread, it really needs to be in conjunction with everything that you're trying to do in the organization, which is best patient care, best patient outcomes. So it's in compliance with patient safety initiatives, quality initiatives, infection control, care management. If you're going to Magnet, one of the key things, key caveats of Magnet is good physician-nurse communication. If you want to be a center of excellence, accreditation, risk management, medical staff services, and human resources. Also, what we're learning now is, one, you want to have the right people at the table, but the other thing is now you're going to need to extend all of these type of communication beyond the walls of your group practice or your hospital across the entire spectrum of care, and this has become particularly important when we move into episode and bundle payments. So what are the rewards? Good communication will lead to communication efficiency and better process flow. There'll be less disruptions and less interruptions, which is a positive for anybody. Is improved understanding and clarification. Hopefully there'll be reduced communication gaps, which means improved compliance, improved coordination, improved satisfaction, reduced complaints, improved outcomes, improved ratings, improved reputation, and pride in a job well done. So in conclusion, and then we'll open up for questions in a moment, there really is growing complexity and more accountability and pressures to change. And, you know, it's hard to give a value judgment whether that's a positive or negative thing. you know, as an internist and doing a lot of care management over all these years, I do think affordability, appropriateness, and effectiveness is the right thing to do, making sure patients get what they need, don't get what they don't need, and understand what is being done and what the risks and benefits are of everything that you're doing, and that's pure communication and understanding. We need to focus on the process and outcome efficiency. There needs to be an efficient process. There's going to be new partnerships, as I said, with the complexity, with the growing number of allied healthcare providers, working with patients, whether it gets physician, nurse practitioner, physician's assistant, clinical pharmacist. All the people who play these roles and others are playing a pivotal part in patient care, and we all need to establish positive relationships to make sure that we're doing everything that's designed to get the best patient outcome. We need for enhanced communication and collaboration. It's teaching communication skills, collaborative skills, building positive relationships, and again, efficiency and information flow and responsiveness. Once we train people on understanding people's values and attitudes and behaviors, more effectively train them on communication and collaboration skills, then the next step is to get them timely information and meaningful information where they can respond appropriately to all of the responses that are communicated to the entire healthcare team, and you wind up getting a better coordinated effort, which can only improve productivity, efficiency, and outcomes. Staff support. As I said, you can't just jam communication skills down somebody and hope that they digest it. It behooves the organization to get a finger on the pulse of what's going on. I mean, culture is all the individual attitudes of people who work in an organization and how they behave. What you really want people to do is to align patients around patient-centric care. So the physicians, the nurses, all the staff are a precious resource. Work with them, find out what their concerns are, and see if there's anything you can do to help. Some of it may be behavioral modification. Some of it may be financial assistance. Some of it may be administrative assistance. Maybe we'll have to change the call schedule. Maybe we won't put you on this committee. Maybe we'll help somebody do some of your medical records work. They're all just trying to do their job. They're under a growing amount of stress and frustration. And as I just said, provide proactive operational, educational, behavioral support. And really, in the end, what we want to do is we want to make this a pleasant place to work. I mean, this re-energizes values, it re-energizes their productivity. So we really need to enhance physician, nurse, staff, and patient satisfaction. And a lot of this has to do with understanding and providing good communication and collaboration. So with that, I'll open it up to any questions, and I'll turn it back over to Leanne.
Great. Thank you so much, Dr. Rosenstein. You really shared a lot of great information with us today. I have had several requests for the slides. We will be sending those out after the webinar, but we would like to take this time and allow for the audience questions to be answered by our guest expert. We already have some in the Q&A box, and if you have any additional questions, please type them into the box. So Dr. Rosenstein, the first question is, you mentioned staff should be provided proactive operational support. Can you be more specific and provide a few examples?
Yeah, I mean, not that it's typical, but a common complaint among, for instance, what do nurses and then physicians is, you know, I'm spending too much time doing chart documentation. You're putting me on all these long schedules, and you're putting me on all these committees. So to be a little bit more sensitive to the fact that nurses in particular want to spend more time at the patient bedside, so you need to take that into account, and maybe some of the more administrative tasks can be passed to somebody else. If there's a big issue with nurses with compassion fatigue, which is a growing issue, and it's not just nurses, it's physicians too, try to diffuse them. It's almost like post-traumatic stress syndrome. If you're noticing that they're getting so engulfed with this type of patient care, somebody can sit down and talk to them, whether it's somebody from human resources, whether it's a peer or a friend, or whether it's a coach or a counselor. We're seeing more and more coaching and counseling being offered to individuals to really help them better adjust. From a physician perspective, they don't like the intrusions. They don't like the fact that now they're going to have to change their processes of care, that they've got to jump and sign this particular thing. They have to follow a specific algorithm. Who are you to tell me what to do? So in that particular case, you really need to listen what the physicians are saying. I'm having too much call. I don't have enough time to spend with the patients. You keep on scheduling for this and that. I don't have enough staff support to help me do what I need to do. So you need to be able to listen to that, and you also need to be sensitive. So the biggest complaint about physicians is they don't have any input. Nobody listens to them. You're telling them what to do. So giving somebody the access to have input and responding appropriately when you can't do it, explain why. But if you can do it, that will bring them into the system. I think those are the two biggest issues on proactive support.
Great. Thank you very much. Next question is, could you please expand on emotional intelligence and what can be done about it?
Sure. There's a lot of research out there, so and there's a lot of it specific for the healthcare arena. So I certainly suggest you follow up. The whole idea about emotional intelligence is your awareness. It's almost sensitivity training. Your awareness of how your actions are impacting the other individual, based on what the other individual's values and attitudes might be. So what you can, let's say you have an elderly patient who's got a English as a second language, is in a low socioeconomic class. What you're going to do is say, we're going to do this, we're going to do this, we're going to do this. What you need to do is, how are you feeling? One of the things we're going to recommend is to be able to get to physical therapy. Is that something you're able to do? How can we help you logistically? Is there anything else bothering you? And getting into what you're trying to do, one is to find out how they're responding to what you're telling them or asking them to do, but more importantly, find out what's on their mind in order to give a better prescription. Not everybody needs to have surgery. Not everybody needs to have a chemotherapy. Some of it is a better understanding, for instance, of palliative care or comfort care, but it's really to set expectations, to be a better communicator, you need to understand what their values are. Emotional intelligence is having the skill set to ask probing questions to understand where this individual person is and where they're coming from and what they really want to get out of the interaction.
Great, thank you. The next question is definitely very timely given all the technology that's out there, and that is, with all of the computer entry required, how do nurses make that eye contact and show attentiveness when trying to input information and assessments at the bedside?
Yeah, great question. I think that's a key to the matter, the key to the world. Having technology and ready cumulative information, which is coordinated, and having it readily available in a timely manner is a key to efficiency. But that's the efficiency. The other part is the personal contact and how much a human factor role plays in not only understanding but also helping to get the message out. I think organizations really need to understand that this is a particular concern about those who are spending time on computers. What we need to be able to do is to make sure, yes, they're doing what they need to do, but at the same time to develop a time schedule they're actually spending time with the patient. Some of the bad examples, one thing is pulling the nurse away from the bedside and doing the computer. Maybe you have the computer by the bedside. But even like a physician in the office, what you don't want to do is just sit there and type in the computer and not make eye contact and not talk to the patient. The eye contact and showing that your interest rather than a distraction has a pivotal impact on satisfaction and compliance. So the organizations that are mandating these types of, we need to do this electronic entry, need to be sensitive to the fact that at the same time we still need to make a time available at the bedside, and if nothing else, make sure that people have physical contact and eye contact with the individuals at some point of their day.
Great, thank you. Here's the next question. Oftentimes these communication challenges are brushed off as colleagues simply needing to be nicer to each other. When do you know when it's gone beyond this?
Good question. It's all, the thing is, what's in it for me? That's what I always hear, particularly with physicians. One, you're not a physician. Don't tell me what to do and what's in it for me. All of these things need to be rallied around what best patient care is. That's why I spent so much time in the beginning talking about what best patient care is. We need to align with that. So best patient care is, one, appropriateness of care, effectiveness of care, timeliness of care, efficiency of care. You have no patient safety, bad patient safety outcomes. You have good quality, and everybody is happy. That's what we're all here to do. Would you agree? Yes. How do you think people get to that state of recognition? Is it the fact that you gave them this different antibiotic and their pneumonia appears to clear and they're fine? Or is it the fact that you're sitting down and talking to them and making sure that they understand what you're doing and assessing how they're feeling? The same thing with the healthcare team. As they recognize how important communication is to all the staff members and how all of this is communicated to the patient, it's all about getting the best patient outcome. And there's a lot of research out there that shows that people who have been well communicated with are more satisfied, are more understanding of their disease, get better outcomes, and are more compliant with follow-up care. So the message is, this is important. You need to understand the downstream effect, and the downstream effect is how that patient feels at the end of the day.
Great, thank you very much. I have one more question here. You mentioned an increased need for collaboration and relationship building. I think a lot of hospitals have done a lot of work in those areas, but is it time for us to be thinking bigger and looking at the processes and tools to make communication faster and more effective? Where would you recommend we start if we're ready to take that leap?
Yeah, well, I think some organizations are already taking that leap. I already established hospitals and systems, and I said some medical schools. So the idea is at least to get people to understand that they're now part of a team and how important communication is. So that's a big step, and it's starting. But with a hierarchical system, particularly in some of the older institutions, it's a tough nut to crack. That's why the business case is everything that we talked about, particularly when I start looking at that metric report card on pay-for performance or penalty, they can see the business case for that. So having an understanding of how important that is for relationship building is key. The next most important thing is, okay, you got the team on board. They understand what they need to do. How can you get the information to them in a timely manner that, one, they can act on it quickly, two, is their responses are delivered to all members of the healthcare team, and then three, all of this is coordinated by whatever the next step is. And that's the growing use of either handheld technology or whatever to make it real convenient for the messaging to go out with the individuals. Then they understand they're going to get the message. They understand what they need to do as far as follow-up. That's definitely the next step and what needs to be done.
Great, thank you. Next question is there an opportunity? So, I think sometimes folks feel like they're Walmart greeters or assistants in the Home Depot who wear the Ask Me Anything button, but do you think that patients are interested in the ask concept and want to know that someone's available to them?
Yeah, that's great. I mean, part of it is we talk about the willingness to speak up, whether it's assertiveness or not, and that's part of emotional intelligence. You've got a patient who's under stress, they're sick, there's a hierarchical white coat or a white gown coming into their room, and they're afraid to ask up. So we need to encourage patients to be able to speak up and ask the necessary questions. But at the same time, the people who are probing with the patient, whether it's the doctor, the nurse, or whoever, need to be able to open up that door to allow the patient and probe them to feel at ease to ask all of that. So for many patients who just don't feel like they can have the wherewithal to speak up, we have to try to really encourage them and make them easy. What we are seeing is because of the all the accountability and all the public domains of all the data, and some of the patients going through and learning about everything through the internet, right or wrong, that they speak up on their own, but that's still a small amount of the population.
Great, and that actually ties very much into the next question, and is, do you think the Affordable Care Act is going to improve the overall health of the U.S. population, which we could probably do a whole webinar on?
Good. It's an easy question to answer. It's a yes and no. The yes is, and this actually ties back to the last question I answered, the yes is that now people have more access to care. The problem is, and please don't take this the wrong way, is that some of the people who now have access to care part of their healthcare problems are due to some of their own individual problems. So the issue is we need to get, now that they have new access to care, great. The other thing is what we really need to work on is having these patients understand the importance of compliance in doing the right things and not doing the wrong things, and that's going to be a big challenge. So you may be getting different types of patients in who are just not going to sit and digest everything because they don't understand or whatever. It's going to make more time and effort on the providers to really make the patients be more compliant, and then you're talking about all the financial consequences of all that time spent and the problems with compliance. So patient compliance is a big issue, and it's a big issue now. I mean, the biggest reason for readmissions is poor patient compliance, whether it's medication, diet, or whatever. But with a new group like this, who are new to healthcare, working on compliance issues is going to be a real struggle for individuals.
Great, thank you. So this brings us really to the top of the hour. Many of you inquired about the recording of today's event. The recording will be posted to Perfect Serve's website tomorrow, and watch for a link to in your inbox as well, which will also include a link to the slides. That really wraps up all of the questions for today. In addition to the tools and resources that Dr. Rosenstein shared with us today, having the right technology in place to support the process is essential. For those of you who may not be familiar with Perfect Serve, we're an intelligent, unified clinical communications platform really designed to help better coordinate care. Before we wrap up today, I also wanted to share with you some of the additional resources available to you on this topic. The first three can be found on Perfect Serve's website in the Knowledge Center, and the fourth item is in Dr. Rosenstein's website that contains a great deal of additional content for you. For any further questions, please feel free to reach out to Dr. Rosenstein or myself. Dr. Rosenstein, I really want to thank you again for being our guest expert today on what is a very important topic. For all the clinicians and participants out there, we greatly appreciate your time and for joining us. I hope you have a great afternoon, and that wraps up our call for today.